So for my child who's now going through OIT, and hopefully it's successful, there basically would never be a point in his life that he wouldn't have to carry his EpiPen with him.
It's a $1 million question. Okay, so
Allergies are the worst. I know because I have had them for so long. Today, we're talking to Dr. Burcin Fraser. She is a board certified allergist. She practices in the DMV area in Maryland. And today, she's going to talk to us all about different ways to combat allergies, hopefully solving long-term allergy issues and getting you out of having to take allergy medications every day. Welcome, Dr. Fraser. Thanks for being here.
thanks for having me.
All right, let's get into it. So we met because my son has an allergy to hazelnut, pecans, and walnuts. And one of my other friends, who is also an allergist, recommended me to you. And we started seeing you, and I learned about this fascinating world of OIT. So can you just give the audience an overview of what OIT is, which stands for oral immunotherapy, and what it's primarily used for?
Absolutely. So oral immunotherapy is the practice of giving small amounts of a food that someone is allergic to in a progressive manner and building them up to a maintenance dose to allow their body, their immune system to become educated and relearn how to be tolerant to that food. So we use it for food allergies.
And what age should you start it at?
Well, for many, many years, it was only studied in ages 4 and above. But recently, in the past, I'd say 5 to 10 years, we've realized that actually we need to start much younger. The immune system is much more plastic and flexible when children are infants even. So I actually start them as soon as we know that they have an allergy. So even a 6-month-old can start oral immunotherapy in my practice.
And is it pretty much any food that anyone is allergic to is something that could be treated with OIT?
So technically, yes, you can pretty much desensitize to any food, but it's still a medical procedure, right? So we do no harm. That's always our first thing. And we have to weigh the risks and the benefits of certain foods and doing this procedure with children and older, infants, children, and adults. We have to decide, okay, is this food in particular something that might be a long-term allergen? Okay, so milk and egg, for example, many children will outgrow that on their own, even if we did nothing, even if we had no intervention. Peanut, tree nuts, and sesame, for example, though, are much more likely to be lifelong allergens. So we choose the procedure to be done in people where it's going to be the most impactful and the risk benefit ratio is favorable.
So what's interesting is that when I was trying to learn more about this, I also learned that not a lot of doctors do it, even people who are allergists. So can you explain a little bit as to why some people don't do it?
Sure. I mean, it's been a long journey. Oral immunotherapy has been practiced for decades. It's been in Europe for much longer than it has been here. In the US, we definitely have a history of more rigorous, clinical trials before we change our guidelines and our practices. And I would say we've been much more conservative about it here because we were always afraid that we were going to induce reactions or anaphylaxis. And those are potential side effects of doing oral immunotherapy. So I think that's why it's taken a little bit longer for us to kind of get on board with it. But more and more evidence is showing that it's so important to actually get on top of this sooner, and that actually with infants and preschoolers, there are much less reactions that happen. So we're really trying to bring it more into the mainstream because there are significant benefits that are clear now. But it's just taken a long time to get here.
Yeah, so it's interesting that you mentioned that because I know with my son, you had said that, his reactivity was fairly low on one of the allergens. And we did have this discussion that, oh, he may outgrow it, he may not. And that's so tough because as a parent, I was like, well, do I do this with him for the next 6 to 8 to 9 months, which obviously is a lot to take on, or do we hope that he just outgrows this allergy? Is there a certain point where you're like, okay, 5 years old, he hasn't outgrown it, he's not going to outgrow it? Or like, is there a critical time period where you might tell a parent that, oh, this is unlikely at this point that he would outgrow something, like an age limit?
There is, and based on my experience, what I've seen is that 3 years old is really pushing it in terms of being able to really outgrow something. So if their numbers are high by that point, I never say we're going to cure this, but there are two kind of goals. We can get a person eating the food on a regular basis, even if they're not cured. So that part of it, there is no real age limit, okay? But, if I'm saying that we're going to potentially drive up the tolerance and drive down the allergy reaction to the food, that and then potentially cure it, that's a big word, but the likelihood of that happening is going to be more when we start as an infant up to age like 2.5. There are these kids who, their numbers look like they're low and there's a chance that they might outgrow it, but then sometimes like between age 2 and 3, I just see those numbers shoot up and then they don't come back down, especially for nuts and sesame. So you're kind of gambling, unfortunately. And it is a really hard decision to make. And just we don't have sophisticated enough tests to predict who's going to outgrow it and who's not.
So just to give everyone an idea of what it's like as a parent who's going through this. So I go into the office once every 2 weeks, and that is when we do the up dose. And at home, I'm giving a very small amount of the allergen to my child every day, usually mixed in with some kind of food, and then watching for a reaction. The first one we did in the office with Dr. Fraser, and then now we just do it at home. And then every 2 weeks, we increase the dose slightly. But for the increase, we're in the office. And tell everyone why we're in the office for that up
Oh,
dose.
sure. We're in the office for the up doses. I kind of think of them as like mini challenges. Like we just need to make sure that the child is going to tolerate that dose. There's no guarantee that just because they were okay in the 2 weeks prior that they're going to tolerate the higher dose. We have protocols that generally are pretty safe and not, we're not too conservative, but we're relatively conservative to keep it safe for children. But we don't know exactly what's going to ever happen. So for example, the other day, I had a child who's just a little more sensitive and she reacted to her updose, even though she'd been doing great all along. Luckily, we haven't had any major reactions to updoses. They're typically mild, but it's also an opportunity for us to demonstrate to the parents, like, see, this is a minor reaction. Let's kind of tweak the protocol or make sure you're mixing the product really well, because it may have been touching the lining of the mouth or the lining of the stomach. Frequently, children will have stomach aches. So it gives us a chance to talk about side effects, allow the parents to really understand, like, this is a side effect, but it's also showing us that it's working, and it gives them hope and it tells them, like, okay, don't be afraid of this, but we have to kind of push through, keep it safe. And it also gives parents a chance to ask questions. They always do, even though they're coming in every 2 weeks. This is kind of like a marathon, right? It's not a race. And that's what I always tell parents. We are in it together, and it's something that we're working through together for each child.
And when does it end if it is successful?
Good questions. For infants and toddlers, we really don't have a lot of long-term data. We don't know, if you're in it for 3 years, 4 years, is that the end of it? Like, do we ever stop? Recently, there was a study that looked at children who were on maintenance, so preschoolers on peanut maintenance for a year. Then they took them off, and 2 months later, they challenged them. So they tried to see if they can now tolerate it, even though they hadn't been taking it regularly. And only 20% of them were tolerant. So that means 80% of them were not. So that is just not long enough. 1 year of maintenance is not long enough. And we know that even from our data from allergy shots, okay, which we'll talk about. But allergy shots have been, we've used allergy shots for 100 years in this field. And we know you have to be on them for at least 3 to 5 years for them to be effective. So why would this oral immunotherapy be any different? The longevity of the treatment helps to stabilize the tolerance, the T regulatory cells and all the parts of the immune system that are trying to remember that this food is okay.
Now that you mentioned allergy shots, I do want to switch gears a little bit and talk about allergy shots because I also have terrible pollen allergies and I've just managed them with over-the-counter medications like Claritin, Zyrtec, whatever, Allegra, everything. I've used it all. And now I feel like in the last couple of years, the pollen has gotten so bad. I don't know if it's my imagination or maybe you can verify if that's true or not. But what are my options when it comes to potentially getting rid of these quote unquote, I know not forever because we just kind of discussed how it wouldn't be forever. But first, has pollen gotten worse over the last few years?
Absolutely. So we know that climate change is significantly affecting pollen levels in our area. It affects the length of the pollen season. So tree pollen season starting earlier in January, and then it's lasting all the way until the end of May. And then grass pollen started earlier this year. So you are not wrong. Every single year, I'm just seeing the pollen season lasting longer, the intensity to be, more significant. And so I've put so many more people on allergy shots this year than I have in my life because people are coming in and they're absolutely miserable. So we treat allergies with medication, avoidance as much as possible, but you can't not ever go outside on a beautiful day. You want to be able to enjoy life, right? So allergy shots are a way to, again, train the immune system, re-educate it to not be so reactive when it sees pollen or other, indoor allergens like dust mites and cats and things like that.
What's the success rate in terms of taking allergy shots for reducing a pollen allergy?
It's very successful, but everything, is a bell curve. So I usually tell people on average, there's at least a 50% reduction. Okay. But there's going to be some people who have, 80%, 100%. So some people will come back in the pollen season the following year after starting their shots, and they are just thrilled because now they can actually go outside. Maybe they have to take antihistamine here and there, but it's nothing like it was before where they were taking 2 or 3 or 4 medications for months at a time.
Hi, everyone. If you've enjoyed this interview thus far, be sure to hit the like and subscribe button below. It not only helps the channel, but helps out all the people that we interview. Thanks for watching. Oh yeah, I mean, I'm talking about like being up at night with the ear itching and the throat itching, and I never had that before. I used to only have it if I ate like apples or peaches, which I know we had talked about this earlier, and you educated me that my oral allergy syndrome was actually from my pollen allergy and
Yes.
not a food allergy. So it's not a true food allergy, which I didn't know. So how long until you start seeing results to that kind of 50% reduction if you're taking allergy shots on a weekly basis?
Well, allergy shots work this way. We have to make serum that's specific for you, like your little cocktail, okay? But we have to dilute it down and then we have to build you up on it. We can't just start you on the high potency stuff, okay? So classically, you come in weekly for a year to build up from low to high dose, which is maintenance. That takes a year. So like 52 weeks of coming in to build up, and you're not feeling better in that time. You just have to have faith in me and the stuff that it's going to work. Okay. But once you get to maintenance, you will feel better. So that means if you want to take that route and you want to feel better by next spring, you got to start right away. Okay. And you might not even get there. Sometimes you can come twice a week, and that'll take 6 months, and you'll feel better by the following season. But in my office, I also do some more rapid desensitization protocols. So if you're healthy and you're, a good candidate, you can come in and get multiple shots in one day every week for 8 weeks. And so we call this a cluster schedule. And then by that 8-week mark, you're at the maintenance dose and you're actually feeling better already, but it is a procedure. So you do have to get your vitals, and we give pre-medication like steroids and montelukast and antihistamines. So it's not for the faint of heart.
Yeah, I'm just imagining like walking out of your office with like puffy eyes and like just like a swollen lip. I'm like, what do people look like when they walk out? Do they look normal?
They look normal. Yes, if that happened to you, you wouldn't be able to continue that procedure.
Yeah.
So we want to avoid that. Yeah, no, most people walk out looking normal, but they might just have really sore arms, to be totally honest.
Oh yeah, because they're getting several injections
Yeah.
in each arm. Well, you might be seeing me in your office every week for 8 weeks because I am really miserable with these allergies. They're getting worse and worse, and now that you've confirmed that, they're only going to get worse. What about sublingual immunotherapy? Because I've also heard about that, and I actually know someone who said they had success. Of course, I didn't talk to their doctor, but there was a friend of mine who was speaking very highly of sublingual therapy.
So sublingual therapy, there's two kinds, one for environmental allergens and then one for food. So we can kind of touch on the food later if you want. But for environmental allergens, there are 3 FDA approved products. One is Grass Tech for grass pollen, one's Ragwitech for ragweed, and one is Odactra for dust mites. Those are the only 3 that are FDA approved. So there is good success with those. They've done kind of like comparative studies, like for dust mite, for example, they show that if you compare Odactra for 5 years to allergy shots for dust mite for 5 years, there's theoretically, the same response. But what it entails is putting the little tab under your tongue every single day for 5 years. Okay, and what that's doing is it's using the immune response and inducing tolerance through the sublingual route. There are some minor side effects with it, like itching in the mouth or throat sometimes. In my experience, people have often hit a wall with that and then switch to allergy shots. And the problem with it is that you can't do multi-allergen sublingual therapy effectively. There are certainly places that offer that, but what ends up happening is the doses are significantly reduced for each thing. So you could do a situation where you do like grass in the summer and then you switch to ragweed for the fall, and there may be some overlap in between there. So it gets a little messy, but if you want to focus on one type, it probably is helpful. Now, sometimes since tree pollen sublingual is not FDA approved, and the reason for that, I believe, is because there's just too many different kinds of trees and everybody's slightly different, has slightly different allergens, and they're not all cross-reactive. Sometimes I'll make a special concoction for an individual based on their particular tree pollen pattern. And I'll pick like 3, maybe 4 at most, and make a special cocktail for them. And that seems to be pretty effective. And that's a nice kind of bridge, if not, your lifelong kind of tree pollen treatment. You just have to start it 3 months before the season.
So if you have 2 of those allergens that are covered by those 3 sublingual drugs, or let's say you have all 3, you're saying that you can't take 3 of them sublingually, like one after another.
You could, it was not studied that way, but
Okay.
you could. It just gets a little cumbersome.
Like, would you have a reaction if you did, like potentially?
Potentially. So even on their package insert, they say you have to have the first dose given in the allergist office. And then I usually tell people, for the first like 2-3 weeks, make sure you take an antihistamine with it just to be sure. But the risk of a major reaction is relatively low.
So let's talk a little bit about how the sublingual therapy could be used for food allergies also.
Okay. So sublingual immunotherapy is more and more studied. There's like one pretty good study about peanut sublingual in young children. I think of it more as either a bridge to oral immunotherapy, like if someone's just having a hard time with even the initial dose of oral immunotherapy and we need to back down a few steps. It's a very, very low dose treatment. So compared to oral, which is generally higher doses, and ingested sublingual to the food is under the tongue for 2 minutes and you spit it out, and very, very low dose, lower risk. There aren't as many restrictions as there are for oral immunotherapy, which we actually didn't get into with oral immunotherapy in generally older kids. We require that they don't have any activity for 2 hours after their dose. For sublingual, there's no such restriction. And it does get to the point where the person is probably protected from accidental exposures with sublingual, but they're not to the point where they can freely eat it, which is something you might be able to attain with oral immunotherapy. The other use for sublingual is in older kids who really, you know, aren't gonna be able to get through oral immunotherapy at all, or they're, going off to college, like we don't even have time to do oral immunotherapy, then sublingual is a good way to just give them some protection.
Well, protection's really good, especially if you're going off to college or you're going to be in an environment where you don't know what's going to be in the dining hall food and you don't know what allergens you're going to be exposed to.
Right.
You would still recommend them they carry an EpiPen and that they're
Absolutely.
careful because it's just going to mitigate the reaction. It's just going to reduce it. It's not going to necessarily take it away.
Absolutely. So, even with oral immunotherapy, sublingual immunotherapy, all of these things that we're now able to offer, none of them guarantee that you're not going to have a reaction. So you always have to carry your EpiPen. And I always tell people that's your magic wand. Just have it with you all the time.
So for my child who's now going through OIT and hopefully it's successful, there basically would never be a point in his life that he wouldn't have to carry his EpiPen with him.
It's a $1 million question. Okay, so for him and his age group, what I envision is that we're going to continue this until, regularly until at least he's age 5. And I say that because that's kind of the theoretical age where our immune system becomes more fixed. So he's, OIT tree nut university right now, right? We're trying to teach his immune system to really have good knowledge about these tree nuts. And then we hope that after that, he's not just going to stop learning, he's going to continue to eat it, but that hopefully it doesn't have to be as intense. Maybe he just eats it a couple times a week as in his regular diet. And then what we eventually could figure out is, can we just like challenge him to like a pretty high dose and see if he reacts or not? Then we could say maybe or maybe not with the EpiPen, but the issue is real life is always different than the office, right? So is there a different augmenting factor that is going to be at play, at summer camp when he's running around and it's hot, and even though he could tolerate it in the office, something goes awry, and these things are unpredictable, unfortunately. So, is EpiPen the worst thing? It's not the cheapest, but it's kind of a fail safe.
And why does heat make everything worse when it comes to allergies or to food allergies
Yeah,
specifically?
it's one of the augmenting factors. So essentially anything that raises the body temperature, we don't completely understand the mechanism. Is it just higher absorption through the gut? Is there some other kind of mechanism that makes the immune system see the protein differently? But that is an observed phenomenon. So fever, other viral symptoms like vomiting, diarrhea are also augmenting factors. Exercise, even hormonal changes in young women, like when they're on their periods. All of these things have been shown to be factors affect the way the body sees the protein.
That's interesting. So if my son has a fever, I should, well, text you. But would I not do OIT that day? Would I not give him the little piece of allergen?
That is in our rule book, yes. We
Didn't
usually
read
say
it.
skip it. Yeah, we usually say skip it. Some other practitioners will say give a half dose. So it kind of depends on the protocol and the practice. So there isn't like one way to do it, but we all kind of agree like, hey, just be careful when there's a fever going on.
Yeah, well, also it's just challenging in and of itself to give a 2.5-year-old like something that you want them to take, and they just decide that, oh, they're not going to take it that day, and because they're just, being difficult.
Yes,
Or just being a 2.5-year-old. I don't know if I call it difficult, just a normal 2.5-year-old. So I think even with a fever, they'd probably definitely not want to
exactly.
open their mouth for that. This was super interesting. Thanks for coming on and doing all this education. I know I learned even more, even though I've already talked to you about this at length in the office, but I think it's going to be really valuable for a lot of people who are considering doing this. For anyone watching that is interested in learning more, and also if they're in the DMV and they want to come see you in person, what's the best way for them to get in touch with you?
Sure. You guys can look on my website. It's drfraserallergy.com. I actually have a whole bunch of blogs on there about a lot of the topics that we discussed today. So you can do a little bit more learning there, but you're always welcome to book an appointment with us. I'm happy to speak with anyone. My nurse also does education sessions on food allergies and other things. So we're really interested in helping patients and making sure that we're giving everything we can to families who are struggling.